My name is David Njeru. I'm a Kenyan. I'm a lecturer at one of the universities in Kenya, training clinical medicine students. It's called Egerton University. We have 3 programs at Egerton University: training for the doctors, training for the nurses, and training for the clinical officers. I mainly train clinical officers as much as I teach the other programs. I have been teaching for the last almost 20 years in the university, but I also taught at mid-level training college. Clinical officer is a very dynamic program, one of the most dynamic programs in Kenya. It started, as you may know or you may not be knowing, as a certificate way back in 1928, during the pre-colonial times, and they did a very good job at that time, even without a syllabus, without a curriculum. Then in 1964, when Kenya gained independence, most of the British doctors ran away because of fear of retaliation by the Africans. So there was a crisis in the health sector. So the government came up together and said, now there's a crisis, what do? We have to train a cadre very fast to meet this gap, because our community is dying because of minor illnesses leading to complications. So the training of clinical officers was accelerated in 1964. Later on, there was the issue of, as usual, doctors feeling that there are other people coming on board, walking around with the stethoscopes, and we didn't like that. So the program was stopped in 1967. And the doctor who was training from Britain, called Dr. Torres, was repatriated. When he was repatriated, after a very short time, there was a crisis in the health sector again. And people realized that actually there is a cadre that is missing this. So it was restarted immediately, and the curriculum developed, and formal training now started in 1969. So it was moved from Machakos, level 5, to Nakuru, KMTC. And from then, it has been training clinical officers. Then again, in 1970, there was a crisis of specialty. Eye problems, skin problems. At our national diploma started in 1970. And now it continued as a general diploma and special areas in health service. Right now, clinical officers are being accepted as a cadre in Kenya. As you may not be knowing, there are 17 cadres in health. All of them have an interest in one person called the patient. But the clinical officers have a scope of practice, so they know their limits, and beyond that limit, they refer appropriately. So the quality of care by clinical officers is very good, and possibly it's maintained because of the requirement of their license to have continuous professional development points. So they are recognized, but as usual, in a cadre that is dynamic, there is always need for improvement, especially in the environment of work. GACOPA is a very welcome association, and I think this is the way to unite all the clinical officers globally. Regardless of the many names that appear in each country and they are registered, we require one umbrella through which clinical officers can work, share experiences, exchange of faculty members, exchange of programs, exchange of even students. Like I've been pushing for the student recognition by GACOPA, and I'm happy that it was recognized yesterday during their executive meeting, because students should also know professionalism and the culture of clinical medicine practice in the world. So GACOPA should be strengthened and should be encouraged to bring all institutions and countries training clinical officers on board. I don't really talk so much about the name. As much as it's very, very important to have a common name, so that the United Nations, the World Health Organization, the International Labour Organization can recognize as one cadre, like the doctors, the nurses, which started a long time ago. But even in practice, the community calls you a doctor because of the services that you have given. It is very important we have that name. But again, it may not be very easy because of the policy guidelines in each country and the politics. As you know, there is politics behind every profession. And I'm happy as of now because even many countries like the USA have found that there is need to change the name because they are really not assistants and they don't have to associate with anybody to work. So I think going forward, I foresee a common name in a very near future. Already there is an existing name that the World Health Organization is using to address the cadre, accelerated medically trained clinicians. I remember that name was coined in 1915 in Addis Ababa, Ethiopia. I was one of the persons who were opposing that because I didn't know where it was coming from. But now, if we have to be addressed by an international body, it cannot call us in all the 26 names. So to me, that is a working title, definitely not befitting because it's a description, but I think we will get a common name in the near future without losing our individual countries' titles, because there is a reason why we have that. But at an international level, we require a common name. GACOPA is going far, as the way I'm seeing. It may change the name GACOPA, because GACOPA means Global Association of Clinical Officers and Physician Assistants. Those are only 2 among the 26 titles floated. So once we come up with a global name, GACOPA may also change the name. I think GACOPA has capacity to unite all the clinical officers globally. We have Asia here, we have America, we have Europe, we have Africa. Australia, New Zealand is easy to reach. So we are talking about uniting clinical officers throughout the world.